Thank you so much, Dr. Parsi and Helen, for joining us today. If we could just get started with learning a little bit more about each of you and how your work impacts our primary care system. Dr. Parsi, why don't we start with you?
Sure. Thank you, Nishita. Thank you for having me and Helen. We're excited to spend some time talking with you. I'm a family physician. I After my residency, I did rural family practice for about 18 years exclusively. But I was also interested in how operationally we can improve primary care and improve primary care specifically in rural areas. So after 18 years working clinically exclusively, I was transitioning into an administrative role and became a chief medical officer for a healthcare system for about 6.5 years. In that time period, the CEO resigned, so I was interim CEO for a period of time. And then most recently, in November of 2022, I joined Texas A&M as the executive director of the Rural and Community Health Institute, where we're supporting primary care mainly, but rural health care in Texas and throughout the state. So I've done it clinically, and now I'm trying to help in more expansive ways to help with advocacy and legislative changes and operational efficiency to help with rural primary care.
Yeah, so I'm Helen Kent Davis, and I am a senior policy advisor to the Texas Primary Care Consortium, which I've done for the past year, just about. Prior to that, I worked for more than 30 years at the Texas Medical Association on healthcare policy on a whole wide range of issues, including primary care. That's really kind of where I cut my teeth at the association, working with the committee on primary care, rural health, and others. Have a lot of experience and interest in the topic, both professionally and personally. And then this past about 6 months, I had the pleasure of working with Dr. Parsi through the Archie, as well as the Texas Academy of Family Physicians, with whom I also work, Texas Health Institute, and the Texas Organization of Rural and Community Hospitals on a rural health rescue plan. Just trying to bring attention to the many, many challenges that rural communities face, providing and protecting maternal health services. So primary care is kind of where it's at, if you ask me. And I also grew up in West Texas, and so out there, I had a longtime family physician who we just adored, and kind of led me to my interest in that topic.
Thank you. I've worked with both of you, but I love getting context on your history. And before I jump into the next question, which I always love because it's really asking people how, in your own words, how do you define primary care? I would love if you guys could take a minute to describe the rescue plan. It's something that's been shared with our consortium, but if you could just describe what it is.
Sure. I'll talk a little bit about how it was developed. We have been seeing, specifically in rural areas, declining access to primary maternal health care and obstetrical care. And that means that mothers have to travel. If they're getting prenatal care, they have to travel sometimes out of their county, out of their community. That just is logistically a problem. And the trends have gotten worse. So it's not like it was bad, it's bad and getting worse. So over the summer, we talked co-conveners. So the Rural and Community Health Institute, or Archie for short, along with the TFP, Torch, and Texas Health Institute, we decided we need to do something about this. And there's a new legislative session coming up. We need to provide some recommendations, some real solid recommendations to the legislature for them to consider. Otherwise, rural maternal health care is going to continue to decline. And we've seen that results from an outcomes perspective get worse and worse. So, and Helen did the lion's share a lot of this work with her experience. We reached out to over 50 organizations throughout the state, academic institutions, practitioners, hospital CEOs, advocacy groups, anybody that really had a part to play in maternal care, we contacted. And what was exciting for us was everybody responded that they wanted to participate practically. So we developed this assembly, had the assembly meet. We had an in-person session in Austin, as in addition to work groups that were made. We did interviews of experts, gathered all the data together, and came up with this Texas Rural Maternal Health Rescue Plan. And it has 12 main recommendations with sub-recommendations. So that's the history of how it was developed. Helen, if you want to add a little bit more context as to what we think that this rescue plan would be able to do, that might be helpful.
Sure. So we wanted to build on the legacy of a similar rescue plan adopted back in 1989 when Texas faced a similar crisis with rural hospitals closing, healthcare clinicians leaving rural communities, and a real liability crisis, leaving patients without access to these services. And we've looking, where we are now, 25 years later, facing a very similar circumstances that we're trying to preclude that level of crisis. As Dr. Parsi mentioned, across rural Texas, we have not only a shortage of healthcare clinicians, everybody from physicians to nurse midwives and nurses, APRNs, but hospitals that have either closed or limited their maternity care services. And that really fundamentally affects the ability of rural communities to thrive without those services, because to attracting young families to live there, to raise their families, they want to know that their mothers, if they choose to have children, will be safe doing so. And when the clinicians leave, it affects not just the ability to deliver babies, but the prenatal care that comes with it, as well as postpartum care. And Texas, last legislative session, did pass the House Bill 12 legislation to extend Medicaid postpartum coverage. So we really just wanted to amplify that as part of providing that a very important benefit you have to have in place in the rural communities and elsewhere, but particularly in the rural communities, the infrastructure needed to care for women and their children safely. And so going to this legislative session, the strategies that would help do that, keeping in mind that, when you think of rural maternal health, it really affects the entire state, because those women, if they can't get services locally, they're coming into urban communities where we already have a strained healthcare system. But people who travel to Texas, who vacation to Texas, they want to know that they can come here and vacation or enjoy our beautiful state with those resources readily available. So it's all just part of the package. And to the point about primary care, particularly in the postpartum period, but also and when you look at the delivery of rural obstetrical care services, a lot of that is done by family physicians. There's just a continuity of primary care before, during, and after pregnancy. It's part of preserving a strong primary care system in rural communities. So it's more than just the obstetrical care, but making sure those women have, care across their reproductive lifespans, to keep them, again, as I said, their families and themselves safe and healthy. So a lot in the package. It's a very detailed report that's on the Archie website, but we can talk about and highlight some of the more critical recommendations that came out of that report.
Thank you. And, as a new mother myself, I think I'm really experiencing firsthand just the benefit of how lucky I am to have access to my, primary care clinician, and just all the system that is in place for me to thrive, both, as you said, Helen, like before having a baby and then after having a baby, and just how that continues, right? And so you both kind of answered it as you were describing this plan, but if you could, and just in your own words, how would you define primary care? Why is it so valuable? Why is it something that we should keep talking about?
Yeah, I've had different definitions throughout my career that I've thought of. Right now, I'll probably use the definition of holistic healthcare for an individual that is in the matrix of their community. That community might be the family, might be the larger community of that they live in. So it is primary care for the individual, but I'll tell you, as a rural physician, I would care for individuals, but I'd care for their family. And then I would be caring for the community. And for me, that was one of the real joys of being a primary care physician, is having that whole context of being of service to the patients that I'm seeing, but also the greater community that they're living in.
Yeah, I think, as I mentioned, growing up out in West Texas, I spent the summers with my grandparents in a small community, and we had a physician who cared for all the grandkids during the summer, which was usually seemed like every week. One of us was off to her office. But she also had a relationship with my grandparents and my father and my aunt, and so she really knew us, and so that really made an impression upon me about that importance to knowing your family history and being able to take care of them, and as I got older and appreciated, as somebody with a chronic condition, having that connection who can help guide you through the healthcare system, and it's that really important personal relationship. If you're lucky enough to have that with a primary care clinician, we see that certainly in the pediatric community. So many kids, they start off, hopefully with that connection, and maintaining that as an adult, where somebody really is not just providing your preventive healthcare services and primary care, but if you do get sick or you have an injury, we have a very complex healthcare system, and somebody who can guide you through it. And when it comes to maternal health, the same. We want to get women really healthy before they're pregnant, address any chronic conditions. If a woman's being handed off to an OB-GYN, making sure that there's that connection, and when she comes back to a primary care physician, that they it's an easy transition. And those rural areas that often one and the same person. So having that relationship where they've being able to see you throughout your time before, during, and after pregnancy, I just think makes for a better outcome, both from a healthcare perspective as well as a mental one. It's, being a new parent is hard, and having somebody and trust to get you through the clinical piece. And increasingly the non-clinical pieces that Dr. Parsi mentioned. I mean, so much now is around like what's happening in your family, what's in your community. Are you experiencing any kind of interpersonal violence? Are you experiencing lack of food security? Anything else going on that could affect your pregnancy? And if you have that trusted relationship and you can tell them that, so you can get the services you need, that's also super important to better health outcomes. And in my case, my primary care physician out in West Texas, she was just very no nonsense and told us exactly what we were going to do. So she definitely kind of was the law, but we also loved her.
Thank you. And so, okay, through, you guys talking about the rescue plan, I've kind of heard several different issues, right? So there's access, there's workforce, issues too. Through this plan, what is like one challenge, or maybe there are several challenges as you guys just listed, that you're really hoping that this plan could help, prevent or help reduce, really through those 12 recommendations that you guys had listed out, or if you want to share some of those recommendations and really how they kind of, help with some primary care challenge.
Well, one of the reasons why we gave 12 recommendations with sub-recommendations is it is complex and there are multiple components, but there are different types of solutions that can address aspects of rural maternal health care. So there's a lot in this, but Nisha, you actually covered a couple of them. So viability. From a hospital perspective, how can that hospital continue to provide OB care? That's fundamentally a challenge right now for rural hospitals. The majority of rural hospitals that are providing OB services are running at a deficit. for that service line. And that's why many hospitals have already closed OB services. So some of our recommendations are specifically related to Medicaid payments for hospitals and practitioners, so it can be a viable service line. So that's one. You also mentioned workforce. Well, then there's a shortage of workforce in rural areas, specifically with maternal care, which is an even more specialized aspect of primary care. So several initiatives related to expanding family medicine OB fellowships, in addition to loan repayments for practitioners, nurses, and ancillary staff. So several type of workforce related incentives to encourage people to work in the rural setting as part of the plan. And then non-medical drivers of health, we know that that's significant in all of primary care. And I'll let Helen talk a little bit about some of those initiatives, but I would say those are three of the really important aspects of our rescue plan is how can we make these institutions viable? How can we ensure to have workforce? And then the non-medical drivers of health and other ways to help support these pregnant women. Helen, did you want to add more?
Sure. Yeah, I think that, certainly first and foremost that we heard from everybody was, we got to keep our doors open. And that's the hospital, that's the clinicians, that's community services. And that's getting harder and harder to do. Medicaid makes up, for some communities, 60 to 90% payment for births. And as a really low payer, it makes it difficult. So you have to stabilize them first. But there's also other things you can do that connect women and healthcare practitioners to important services. And doing that in a state as large as Texas means you have to have a lot of flexibility. So one of the things that we recommended also was that the state establish grants to help communities build the infrastructure, not just the facilities and the clinicians, but what do you need to bring specialty care services through telemedicine, to connect women to community services, whether it's to address non-medical drivers of health or just thinking innovatively about how do you do home visits for women who might be at high risk and can't travel or just recently had a C-section. And the needs of the panhandle are just very, very different than far, deep East Texas to the Central Texas and so forth. So innovation grants was a big part of that. And communities are, we did hear some really interesting, initiatives that are out there. I mean, the thing about rural communities is they're pretty strappy. They figure out how to tackle problems with limited resources in innovative ways. But so bringing some dollars to that so they can come up with initiatives around, like, for example, do you have not just mobile units to provide preventive care services, maybe regular outposts where women know that if I go here, every third Thursday of the month, there's going to be a clinician that's set up to see me again before, during, and after pregnancy. Looking at things that other states have done, like innovative work with their emergency medical technicians. So you don't have to take an ambulance, but if they're well trained, they could do home visits along perhaps with a nurse or medical assistant to check on somebody who's high risk, who cannot easily travel a long distance. And given in parts of West Texas, there can be huge distances between services. Looking at novel ways to not just telemedicine, which has been widely adopted, though we certainly need to expand it further. But looking at are there apps, for example, that are reliable and secure to connect women to perinatal mental health services or parenting services. It's ideal to connect somebody in person, but you just may not have somebody to do that on a regular basis. But we know that in many small rural communities, mothers might feel isolated. They need social support services. So are there funds to look at that? And around quality, there's a lot of discussion about efforts to improve maternal quality, which Texas has been doing a lot of work over the last decade. But those initiatives cost money, quite frankly, and oftentimes in small facilities, you have somebody wearing multiple hats. If you're the chief medical officer, you're also doing trauma and something else, the nurse the same. So how do you bring dollars to the community so that, for example, we're trying to address hypertension and women who are discharged with that diagnosis getting follow-up care, that they can set up clinics or referral networks that make sure that women don't fall through the cracks. So there was a lot of innovation that came to it, and you have to pay for that. And thankfully, I think legislators, have understand the importance of maternal health, and that the crisis rural communities are facing. They have included in the budget the last several sessions additional funding for rural hospitals in particular. Last legislative session, we're grateful for the increases they provided for labor and delivery in Medicaid. But it's like anything else, it's not just one thing. You have to think about it, comprehensively. If you have a hole in a blanket, you can put a patch on it, but at some point it'll start to unravel if you don't really more fundamentally address it. And so that's what we were trying to show, is it is kind of this concentric circle of suggestions that are necessary to really make sure that you sustain those services, and they're that they're providing high quality care to the women in their community.
Yeah, thank you. Oh, I actually I haven't read the plan yet, so I'm excited to read it. And Helen, I think especially how I've worked with you closely on our policy work through the consortium. I'm wondering, and I'm kind of connecting the last question, which I love asking. It's, if you have a magic wand, what's one thing you would change about primary care? And thinking about our policy work that we did in 2024, the linchpin kind of policy item that we have is payment. It's changing the payment system, right? And so Helen, I heard you say there are all these different innovative programs, but we have to pay for it. And so as we go into this next legislative session, HB 12 having, it's passed, right, from the last session, do you guys feel like there's an opportunity to leverage that, or what is that big focus that will be there through 2025? And I'm connecting it to this magic wand question of like, what's that one change that could happen, this year that could hopefully, kind of help those recommendations and help your work?
Yeah, I mean, I think that we're in primary care. I think, sadly, I think we're past the magic thing, except for payment reform. And it really is, primary care, I believe strongly, is the linchpin of a strong healthcare system. And without it, if we woke up tomorrow and didn't have primary care, our healthcare system would be less navigable and friendly and productive and effective for patients. And you hate to bring it back to dollars, but that really is fundamentally about it. If you can't stay in a rural practice and keep your doors open, then you're just not going to have it. That is not to say that physicians and other clinicians are not amenable to reforming how payment is paid. And that is one thing we talked about a lot as well, is what are some innovative maternal alternative payment models that provide sustainability payments, keep those doors open, but also have an expectation, of course, as we always have, of delivering high quality care with better health outcomes, but be able to measure that while also keeping it simple enough that rural hospitals and clinicians can actually provide the clinical care without getting bogged down in all the administrative work. So I think payment and workforce go hand in glove. You can invest a lot in the workforce, but one of the things a physician told me is, like, I came to rural Texas, I'm so excited to come out here, and just hanging on by a shoestring. So they did all this work to get them out there, and then what do you do to keep them there if you can't pay a fair rate? And thankfully he was able to transition to a new practice where that was able to happen. But it's just, you have to do both. You have to invest in the workforce and then recognize once they get there, to keep them there, all that investment, you're going to have to pay a sustainable rate in the Medicaid program and elsewhere.
Yep, you said it very well, Helen. I don't have much to add. Of course, the bigger magic one, we already talked about payment reform, but if there is equality in pay between primary care practitioners and specialists, and I'm not just talking about physicians, even advanced practitioners, PAs and nurse practitioners, if they go and work with a specialist, their salary will be higher than an advanced practitioner that works with a primary care physician. So physicians and other advanced practitioners, if we had pay equality, I think we would have a better leveling of where medical students and residents decide to practice.
Thank you. Thank you both. This has been such a great conversation. I feel like we could keep going, but I will let you both
For
go.
sure. The passion project for both of us.
Yes.
Yeah.
Yes, it shows. It definitely shows. And so thank you. Of course, people will be able to contact you if they have additional questions, and they'll also have a link to the plan as well. But thank you both, and thank you for all the great work that you do.
Oh, thank
Thank
you.
you.